On this session. Welcome to our first journal club presented by the American College of Veterinary Nephrology and Urology. We are really excited to have this. We've had a bit of a lapse in the journal club that was done through the ACVNU, and we are now revamping it, utilizing the journal club requirement that the residents of the ACVNU need to complete as part of their training. Means that we have a lot of presenters, which is going to be fantastic. So we now have, the plan is twice a month journal clubs. So it's the first Monday and third Wednesday. Do I have that right, Summer?
No, it's the third Tuesday.
Third Tuesday, okay.
First Tuesday. Monday and third Tuesday.
Okay, and they're all posted on the ACVNU website. So we encourage everyone to keep checking the website, both in terms of article details, as well as the link on how to log on. And like always, we hope that these journal clubs will be very interactive. And while we have one person who may be leading the discussion, we really hope that this generates a lot of back and forth and discussions to help us understand the topic and to take things to a different level. So please feel welcomed to contribute to the conversation. You can type in the chat. Feel free to unmute your microphone and to join in. But without further delay, it's my great pleasure to introduce Dr. Stephanie Skinner, who is one of the nephrology-urology residents based out of Friendship. So I'm very excited to have Steph get us started here with leading this presentation. So Steph, it is all yours.
All right. Okay, can you guys see that okay? Does it look like a presentation?
Yep, we can see your main slide.
Great. Okay, so I am going to be talking about a relatively recent paper that came out on the response and survival of dogs with proteinuria treated with ACE inhibitors. Briefly, a little bit of background. I'm not going to go too much into this because hopefully everyone here is aware of everything that's going on with proteinuria, but really we have like the 2004 consensus statement specifically talking about the assessment and management of proteinuria in dogs and cats. And they note even back then that persistent proteinuria has been associated with a greater frequency of renal morbidity, renal mortality, and mortality of all causes in humans, dogs, and cats, and that a UPC of greater than 0.5 is considered abnormal. We specifically have a couple of studies in dogs looking at the association of proteinuria with morbidity in conjunction with their degree of proteinuria. So that first study, the Jacobs 2005 study, was looking at 45 dogs with chronic kidney disease. They used a cutoff of a UPC of equal to or greater than 1 and found that those dogs that were more proteinuric had an increased risk of both developing urinary crises as well as death. That was 3 times higher in those dogs, and that there was a relative risk increase of 1.5 times higher for every 1 unit increase in UPC that we had. So a study that kind of showed that truly proteinuria is significant in these chronic kidney disease dogs. There was also a 2008 study that looked at 24 dogs with chronic kidney disease, 10 of whom had a UPC of greater than 0.5. In that study, when they only split it between greater than 0.5 or less than 0.5, they didn't find a significant difference in median survival time. But when they changed the cutoff to 0.1, they did find that those dogs, again, with UPC of greater than or equal to 2.1, did have a significantly longer median survival time of 390 days versus 1,053 days when it was less than 1. So I think in 2013, we had the IRIS substage subgroup coming out with a bunch of consensus statements on both just like the diagnostic workup of dogs with suspected glomerular disease, as well as the treatment for that. And I think, as we all know, kind of standard therapy for protein-losing nephropathies at this point is to treat the underlying disease, switch them to a protein-restricted diet, make sure you have control of their blood pressure, as well as making sure that you have control of their proteinuria. Where the general consensus is that successful treatment is defined either as getting their UPC to less than 0.5, or a little bit more commonly, having at least a 50% reduction in their UPC. So just because of the study that we're looking at for Journal Club today, I wanted to focus a little bit more on the antiproteinuric side of the standard treatment for PLN. So, and specifically ACE inhibitors, because that's what's used in the study. So generally we think of enalapril and benazepril being our two ACE inhibitors that we're using, where we're starting at a dose of 0.5 mg/kg by mouth every 12 hours. The active metabolites of both of those are equally potent, but just kind of remembering that enalapril has primarily renal excretion and benazepril has both hepatic and renal excretion. So you may want to consider how that might affect your patient depending on whether or not they're already acetemic or not. So a couple of studies have looked at how effective enalapril and benazepril are in dogs. There's some cat studies, but I'm not including those today because the Journal Club article we're looking at was only focused on dogs. So in 2003, we had this model where they did an 11/12 partial nephrectomy in 18 dogs. And then they started half of them on enalapril at 0.5 mg/kg Q12, and then the other half just got a placebo. They found that there was not a significant difference in the change in UPC at the end of 6 months between control and enalapril, but both had a decrease. They did find that there was a significant difference in the degree of glomerular and tubular interstitial lesions at that 6 months, though, and there was no change in the single nephron GFR. And then another study, I think that was maybe a little bit earlier than that one, was looking at dogs that had naturally occurring immune complex GN, so 16 with membranous and 13 with membranoproliferative GN. In that study, they put them on 0.5 mg/kg PO-Q24, and they'd increase it to Q12 if the UPC was greater than 50% at day 30, and followed them for 6 months. They found that over that 6 months, there was a reduction in UPC by 4.2, and that the dogs that received placebo had an increase in their UPC. And then on this table on the right, improvement was defined as dogs with a 50% or greater reduction in UPC with a stable creatinine. If no progression was a less than 50% reduction, and if they had progression, they either had a 50% increase in their UPC, their serum creatinine, both, or the dog was euthanized due to renal failure. All of the dogs in this study were treated with a diet, but they did not assess survival outcomes. And then moving on to benazepril. So this was a kind of more recent 2017 study where they were dosing anywhere between about 0.2 and 0.5 mg/kg per day. The study was set up to be potentially really promising. It was prospective, multi-center, randomized, and blinded. But unfortunately, there was, I think, a little bit of trouble with funding. So initially, to be powered for the differences that there were supposed to be between the two groups, they had planned to enroll 80 dogs, but ultimately they were only able to enroll 49 dogs before the people that were helping to fund the study stopped including new dogs. So looking at just the numbers that they do have, it doesn't seem like there was a survival and benefit on the dogs and benazepril. But they do include some graphs looking at breaking down those populations a little bit. So on the left is the Kaplan-Meier plot for dogs with a UPC of greater than 5. They did not find a significant difference there. So median time to endpoint, which for this study was either death, euthanasia or the need to start administering subcu fluids related to renal failure. So the dogs receiving benazepril had a median time to endpoint of 196 days versus 158 days in the placebo group, but they further subdivided it into dogs that had a UPC of greater than 0.5, but also had less severe azotemia. And again, it was not statistically significant, although it was close. The p-value is 0.08, and they found that in those dogs, the benazepril patients had a median time to their endpoint of 346 days versus 158 days for the placebo group. So I think visually it looks like there might be a difference, although statistically there was not a significant difference. But again, the study was unfortunately underpowered. So the actual journal article that we sent out for today was looking at the response and survival of dogs with proteinuria, defined as UPC greater than 2, treated with angiotensin converting enzyme inhibitors. So the main objectives from the study was to first determine the proportion of dogs who were able to either get to a UPC of less than 0.5 or have a greater than 50% reduction within 3 months of starting an ACE inhibitor, and determine whether a positive response to treatment was associated with improved survival. And then they had a secondary objective of evaluating whether the lab work within 30 days prior to starting treatment was associated with response to treatment or survival. So this was a retrospective study. Dogs had to have a UPC of greater than 2 that were prescribed an ACE inhibitor. I think someone is not muted. That should be muted. There you go. And then they needed to have a baseline UA in chemistry and at least one follow-up within 3 months of starting the ACE inhibitor. Dogs were excluded if the ACE inhibitor was prescribed for non-proteinuric conditions, and if they were receiving concurrent therapy that might affect renal protein loss, so pladia, steroids, ARBs. There was no exclusion criteria for like other endocrinopathies, and because this was in like the UK, I think, where I guess they don't have as much infectious disease concerns, there wasn't any infectious disease screening on any of the dogs. So they recorded for the baseline variables creatinine, albumin, cholesterol, UPC, and blood pressure, and gave definitions of azotemia, hypoalbuminemia, hypercholesterolemia. A severe UPC was defined as greater than 3.5, and then hypertensive or not. And then they also noted the choice, which ACE inhibitor they started and what dose, current comorbidities, and then other non-ACE inhibitor treatment of their renal disease. And then finally, the definition for a treatment responder was, again, that reduction of UPC of greater than 50% from baseline or less than 0.5 at any follow-up visit within those 3 months. Non-responders either didn't meet the threshold for the reduction in their UPC, they started an ARB or corticosteroid before that target was achieved, or if the ACE inhibitor was discontinued due to progressive azotemia or hyperkalemia. So ultimately, they had 85 dogs included, 58% female and 42% male, the median age of around 8 years and a median weight of almost 15 kilos. 15 of those dogs did have concurrent endocrinopathies. Of the 8 dogs with hyperadrenocorticism, 5 were on trilostane, the other 3 were not. 2 of those 3 eventually were started on trilostane, and one wasn't. All 6 dogs with diabetes were on insulin, and the hypothyroid dog was on levothyroxine. They found that for their baseline values, about 40% of the dogs were azotemic. 80% would have been characterized as having a severe proteinuria. Not quite half were hypoalbuminemic, and not quite half were also hypercholesterolemic, and about half of the patients were also hypertensive. So most of the patients did end up receiving benazepril. Only 6 of the dogs ended up on enalapril, and the starting dose was 0.5 mg per kg per day, but it ranged quite a large amount from as low as almost 0.1 mg per kg per day to up to 1.5 mg per kg per day. At the time that they started the ACE inhibitor, 8% of the dogs were on a renal diet, and another third ended up getting started on the renal prescription diet at the same time as the ACE inhibitor. I think 3 of the dogs were on antithrombotics, and 7 of the dogs were receiving amlodipine therapy, which is about 8%, 3 of which had documented hypertension at baseline, even on the amlodipine. So for their overall numbers in terms of response to treatment, they only had 35 dogs that met the requirements to be considered responders. And of those 35 dogs, only 1 dog actually got to that target of a UPC of less than 0.5. The median time to achieving that response was a month, and the median dose was a 0.5 mg per kg per day. Of those 35 dogs, only 10 dogs had another urinalysis within those 3 months, and they note that 3 of those 10 dogs would not have been considered responders on the second UPC that was available. For the non-responders, this was the other 50 dogs. Almost 80% didn't reach their UPC target within the first 3 months. Of the other 20%, it was divided between dogs that were no longer on the ACE inhibitor because of progressive azotemia, about 10% that got started on a steroid, and then another 5% that got started on an ARB. And for these dogs, the max dose was very similar to the starting dose for the responders, which is about 0.5 mg per kg per day, although the high end of the dosing range is much higher. It's to the 2.5 mg per kg a day instead of the 1.5 mg per kg per day. So table 1 is comparing the baseline variables between the responders and the non-responders. There was no statistically significant differences in any of these baseline values. So all of the signalments, but also azotemia, degree of CKD, comorbidities, which ACE was used. And I think kind of specifically to hone in on those clinical variables that we were looking at. So the azotemia, hypoalbuminemia, hypercholesterolemia, severe proteinuria, hypertension, none of them were found to be significantly associated with the treatment response. There was a significant difference in the median survival time between responders and non-responders. So the dogs that were responders had a median survival time of 664 days versus only 180 days for the non-responders. They did find that the median survival time of dogs that were azotemic was on only 175 days compared to the non-azotemic dogs, so significantly longer, but that hypoalbuminemia, and so the first table was at baseline, and this is at 12 months. So hypoalbuminemia, hypercholesterolemia, and severe proteinuria were not significantly different median survival times at 12 months. And just to give you like a general sense of the numbers, of the dogs that were still alive at 12 months, 28 of them were responders, and then the remaining like 40 were not responders. So figure 1 is the Kaplan-Meier survival curve of all-cause mortality for all 85 dogs, where red are the non-responders and green are the responders. And again, where response to treatment is UPC of less than 0.5 or greater than 50% reduction. So clearly a significant difference. And then they actually included quite a lot, like a long period of time on this graph. The actual component of what they were looking at in the study was to 12 months. So if we were able to just like take this kind of first portion of the graph, I think probably would look more significant than it does when we have all the way out to the almost, 4,000 days worth of data. And then figure 2 is the cohort of the 85 dogs who were azotemic versus not azotemic. So here, green dogs were not azotemic, red dogs were azotemic. And I think, again, there's clearly a separation of these two lines. And if you were to get rid of all of the data past the 12 months, I think it would also be even farther apart. So in terms of the association between the clinical pathological variables and hypertension on survival, the continuous variable assessment found that creatinine, which is the blue graph here, albumin, which is in red, and UPC, which is in yellow, were all associated with that 12-month outcome, where a higher creatinine, lower albumin, and a higher UPC were all kind of negative survival indicators, but there was no difference in whether they were hypercholesterolemic or not. So table 2 splits the data a couple of different ways. So I think, first of all, the very first line is just probably the main finding of the study, which is that the responders did have a significantly decreased odds ratio of dying, 0.1 versus the non-responders. If we look at the baseline creatinine values, this is again where we can see that patients that were azotemic had a higher odds ratio of a lower mortality, and that specifically there was a 2.53 increase in the odds of death for each 1.1 milligram per deciliter increase in creatinine. And similarly with albumin, just having hypoalbuminemia was a poor factor for survival at 12 months. And then for every decrease in 0.1, for every 0.1 gram per deciliter increase in albumin, you had a decreased odds of death. So lower albumin worse, higher albumin better. With the cholesterol, it didn't really matter if it was assessed as a categorical or quantitative variable. It was not associated with survival either way. And then with UPC, although dividing patients into severe UPC versus not severe UPC wasn't statistically significant, if you looked at the values itself, for every unit increase in UPC, there was a small 1.18 increase in odds of death. And then with hypertension, again, not associated with, not statistically significantly associated with changes in mortality at 12 months. So with multivariable analysis, in this case, they wanted to try and tease out whether the presence of azotemia and hypoalbuminemia would still be associated with increased odds of death. And they found that, yes, again, the three things that we saw on the previous table are kind of repeated here, which is that either they were responders, which was associated with less odds ratio of death, but if they were azotemic or hypoalbuminemic at baseline on multivariate analysis, that was a higher odds ratio. And then I've never actually seen a categorical tree like this set up before, but I did think it was interesting the way they did this. So they were trying to, I think, tease out the different effects of the different characteristics that we were looking at and how those affected odds ratio of death. So they took the 67 patients that are at the top of this are the patients that had 12-month survival data, but also had creatinine, albumin, and cholesterol available. They only had the systemic blood pressure or systolic blood pressure in, I think, like 25 of the dogs. So they ended up not looking at that as part of this categorical tree. So of those 67 patients, 48% were still alive at 12 months. And then they split them into responders versus non-responders. Non-responders are on the left, responders are on the right. Of the non-responders, they found that the worst outcomes were associated with non-responders who are also azotemic at baseline. So those patients had 0% survival to 12 months, and there were 17 of them. Conversely, if we look at the other side, so the responders that were not azotemic, not hypoalbuminemic, not hypocholesterolemic, those were patients, and there were only 8 of them, but all 8 of those dogs were still alive at 12 months. So I think some of the limitations associated with this, most of them were going to have to do with the fact that it's a retrospective study. So there was not standardized dosing for the ACE inhibitor. And I think we could see that there were fairly low doses. So going back to just like the median doses on the responders versus the max doses on the non-responders, it was essentially the same. They were both 0.5 mg/kg per day. There also was a lack of control of the comorbidities. So we had a number of cushingoid patients, only some of whom were receiving treatment for that. And if we think back to just treatment of PLN is controlling comorbidities, and then other treatments were not controlled. So which patients were already on a renal diet, which patients were receiving appropriate control of their blood pressure, all of those aspects were not controlled. And then of course they discussed choosing a UPC of greater than 0.2 in hopes of only getting patients with glomerular disease. But I think we've seen from studies looking at renal biopsy and histopathological data that we can't use a specific UPC to differentiate glomerular versus tubular interstitial disease dogs. And so really it would have been nice to have renal biopsies to get definitive diagnoses on these dogs and determine exactly what kind of glomerular disease they actually had. I think as a retrospective study, it is still pretty interesting in that we really haven't had great studies looking at survival data with treating dogs that are proteinuric and actually trying to reduce the proteinuria. I think in this paper, the number of dogs that were considered responders was a little bit disappointingly low. Not even half of them got there. But again, I think that it doesn't seem like the ACE inhibitor therapy was maximized in most of these dogs. And I think we also are potentially using more other medications like ARBs at this point and considering whether those might have kind of superior outcomes in reducing UPC and if that's also associated with the improvement in survival time. But ultimately, this did show that there was an improved survival time in those control dogs, and a pretty significant one. 2 years versus half a year is a lot of time for an owner at home. And I think also interesting is, not surprising, but that dogs that were azotemic, that were hypoalbuminemic, and that had higher degrees of proteinuria were associated with a worse outcome. So I think next steps from here are hopefully going to be things like setting this up as a prospective study and hopefully maybe bringing in other medications like telmisartan or potentially being able to compare telmisartan with an ACE inhibitor. Also considering whether those patients that have a lower UPC than the two, right? So if abnormal is greater than 0.5, do we have evidence that treating those patients results in kind of an actual improvement in their clinical survival times would all be really interesting. And I think that, hopefully this study shows that there's kind of space for that and that we should continue to look into that. That is all I have. I went through that a lot faster than I expected to.
Great, Steph. Thanks so much for kicking that off. I was very excited to see this study because it is the first real piece of evidence we have to show a survival benefit. And we like to think that our ACE inhibitors and our ARBs are renoprotective and that will in fact make a difference, but we don't have data to actually corroborate that. So it's nice to actually show that there's something that's there. And again, a really good starting point to jump off. You had mentioned the idea of, looking at ACE inhibitors and ARBs and long-term outcome. I don't know, Bianca, are you guys doing any long-term follow-up on your prospective trial?
Great question. No, but every time an intern comes up and asks me about a project, I do think about going back and just describing those dogs. It always gets a little muddy when it's not prospectively designed, that part, because various things happen to those dogs. But I've wondered about that many times. And I agree, JD, I was really excited to read this paper too. I agree with your thoughts, Steph, as well, on many of many of the things you said, right? Very exciting because it certainly seems to show a benefit. Seems like the ACE inhibitor dose might have not been fully optimized in some cases, based on especially the more recent data that Jonathan Moschel has been publishing based on RAS fingerprint prediction that really seems to indicate that a twice daily administration of 0.5 mg per kg is going to be more optimal to inhibit the RAS. So I think that is true. I don't know if others thought of this too, but I'm always curious about what it means with the responders, because we don't have biopsies, what it means that the responders lived longer, right? Is it because maybe they have a different cohort of diseases, right, that were more likely to respond without the need for additional therapy, or what is it about that? But it's always undetermined, right? When you don't have biopsies and you don't know if those are maybe just different dogs. But
yeah, it comes back to the question, is proteinuria just a marker of severe disease? How much of it is driving the disease? And the dogs that respond, are you getting improved survival benefits by reducing their proteinuria and minimizing subsequent nephron damage? Or were the dogs that had less disease going to respond, and therefore they were going to live better regardless? We don't really have that information. I guess if they live longer at the end of the day, that's what our owners care about. Great, but from a pathophysiologic standpoint, it'd be great to be able to tease that out a bit more.
Yeah, exactly. That's exactly what I keep going in circles in my head about it. But I agree. At least it provides evidence to the use of RAS antagonism in these patients and a survival benefit.
Yeah.
There's so many people on the call. Maybe someone is looking at the question of telmisartan or any other ARBs retrospectively or prospectively.
Another thing that I thought that this paper did kind of just highlighted was we like to have these cutoffs, and Steph, you pointed out that this UPC greater than 2 really can't indicate even glomerular proteinuria, let alone the actual etiology of proteinuria. And as an aside, it's also important to remember that membranous nephropathy is not a disease. It's a reactive pattern. Membranoproliferative glomerulonephritis is not a disease. It's a biopsy pattern. So we kind of hone in on the pattern of immune complex deposition in the kidneys, but that's still not a disease. But regardless, going back to my initial thought, is UPC can't predict that. And so when we talk about UPC greater than 2, meaning it's glomerular, we have no idea if that's the case. We undoubtedly we're going to have some dogs in this study that have immune complex disease that was untreated. I mean, there's no way you can have 85 dogs that are proteinuric and you're not going to have at least a single one where there's immune complexes that are there. But when they looked at the patients with that severe proteinuria, which there are a number of people on who were part of that consensus group who came up with that definition, I'd be interested to hear their thoughts on it. But as far as I'm aware, that cutoff of the UPC of greater than 3.5 indicating severe proteinuria, I think it's just opinion-based. And this study did not find that there was a difference in survival in those patients who had UPCs greater than 3.5 or less than 3.5. But the magnitude of proteinuria was associated with survival. So if you think of it like a continuous variable, the way I and my mediocre brain understands it, the worse the proteinuria is, the worse the survival is. But to say that something different happens at 3.6 versus 3.4, that cutoff, I think, and correct me if I'm wrong, sub-panel members who are on here, but I don't think that's data proven, and it wasn't substantiated here. So when we try to grasp onto those cutoffs of UPC of 2 is glomerular, 3.5 is severe, I don't know if we're actually doing ourselves a favor by that, or if we're actually creating these definitions that might not actually be helpful.
So I was on those panels, so I'll address a little bit of it. And it was opinion. It was at some point there was some data, and I cannot pull my brain where it was, that correlated UPC to 24-hour urine protein. It was back like in data from the 80s probably. And so I think there was an attempt to come up with that 3.5 to correlate what went along with what was considered nephrotic range proteinuria in people. But it was an educated guess. It wasn't anything that, was very clear. We've documented this, we've proven this. And I think that I absolutely agree with what you're saying about that there is no magic number by 2, but I think that you're talking to a group of people who think a lot about this and who are, in the weeds more and more educated about like what you're saying, and that membranous isn't a disease, it's a pattern. But when you're talking about taking it to a private practitioner and trying to get them to react differently, I think our decision at the time was that we needed to give them some number above which it was likely to be glomerular disease. Not that it was diagnostic of, although that original paper that Sharon Center came out with, went further than that. Like, I think that's where some of it was. They even said that if it was, I don't remember the number now, but if it was like above 10, it was amyloidosis. That had to be it. So for a long time, I would fight with the pathologist that they'd say, well, you already know it's amyloid because it's got a urine protein creatinine ratio of 15. And I'm like, no, we don't know that. That's why you need to do this test. You need to biopsy or you look at our biopsy. So, I think it was more of a, how can we best serve the average practitioner, not how can we best serve the group of people who are interested in veterinary nephrology. And that's why at the time we came up with a number. And it, again, I think it did get morphed into, if it's less than 2, it's not glomerular. If it's greater than 2, it is glomerular. But that was never the intent. The intent was to give somebody a number to use as a guide. And I still think there's some merit in that when you take it outside of this group. Because, even considering immunosuppressants, when do you get them to start thinking of, do you do a SCSH gel electrophoresis? When do you move forward with additional diagnostics? And when do you say, well, I'm pretty comfortable that, those aren't needed? And then, of course, since then, when we have all these biopsies, we see a lot of dogs that have a urine protein creatinine ratio of 0.5 or 0.4 that have glomerular disease. And I think that, that's a very real phenomena. But again, those aren't the dogs that are necessarily dying from their proteinuria. And anyway, that's, I think, where we were coming from when we put that together. I see George just turned his video on, so I'll let him.
Yeah, you're in trouble now. First of all, it's always dangerous to try to draw fine lines through gray areas. I mean, you just, biology doesn't behave that way, does it? So, and so cutoffs become useful for statistics and a variety of other things. But when you're thinking about your patient, you know that more proteinuria is worse than less, and that 9 is worse than 1.5, and 3.5 is somewhere in between. But you'd rather it not be 4 or 5 or 6 than 2 or 1.5. But actually, the paper isn't the last study that needs to be done, but it's a useful information. Going back to what we've talked about, I'll restate what's been said before and just slightly differently. In a sense, there is a way of looking at the results of the paper, that it's useful information whether the ACE inhibitor is causing the longer survival, or it is just identifying patients whose disease is going to let them live longer. Okay. And so maybe it's the 60% who don't respond, by their criteria or something similar to it, that are sort of statistically destined to not live as long unless we find out more about their disease and figure out what might be done about it. So may and one of the arguments in the paper is sort of how practitioners operate. They see proteinuria, they feel like they've been told they should do something and put them on ACE inhibitor. But then the next question, it's sort of like, I'll use the analogy to blood pressure. If you have hypertension and you put on antihypertensive drugs, then you have to find out whether the blood pressure goes down, whether it's adequately, for your purposes, controlled. And if it isn't, what are you going to do next and when? And maybe it's part of the emerging story is to figure out what really should be done next if they're one of the, in this case, 60% non-responders who are apparently at greater risk for shorter survival, whether it's caused by their unwillingness or inability to respond to ACE inhibitors alone, or because the drug isn't able to make a big enough difference. So. It's a commentary, not a question or an answer.
Well, it's commentary that is much appreciated, George, certainly from your vast expertise here. Any other thoughts or comments? I don't want to steal the microphone from everybody. We have over 70 people on the rounds, which is terrific. Any other thoughts? There was some comments in the chat whether this could be. Are we seeing an effect of, again, as kind of what we're bringing up, of the patients that are just less severe? If you're azotemic and proteinuric, those seems to be the worst survivors. So is this just a benefit of those patients that are not quite as severe in their disease? And I think that's certainly a question that is only probably partially answered by looking at creatinine. It's probably a matter of their body condition score, their quality of life that's assessed by the owners. It's a lot of different things, but some interesting thoughts in there. Aria, you raised your hand. Would you like to speak?
Yeah, hi. I also think we potentially don't know enough about the effect of concurrent diseases on proteinuria, especially because I know we've talked about this on the listserv, but I recently had a dog with Cushing's disease that started out with a UPC of 10. And I treated the Cushing's very aggressively, and I put him on telmisartan, and his UPC is now 0.8. And I didn't check one in between doing both of those things. I did them both at the same time, but I don't think I've ever seen that dramatic of a response from just starting a dog on telmisartan. So I hope that we can further investigate those concurrent diseases as well.
Yeah, I think that's a good point. And there are some dogs that just seem to love telmisartan and they respond so well to it. And there are those that laugh in the face of it, despite everything, every dose you try. Bianca, do you want to follow up on that?
Yeah, I was just going to add, for whatever's worth, in the study we did here, we had a dog that went from a UPC of 11 to 1 in 1 month. At the time I was masked, so I didn't know, but the dog was assigned to telmisartan, and it is crazy. The UPC had been repeatedly very, very high. It wasn't always 11 because we know there's so much variability, but it was definitely above 3.5 repeatedly for a few months, and then within 30 days was down to 1. So I also can't explain it very well, but it's a dramatic response in some dogs.
Yeah,
we did a study that was published as an abstract, but never in a peer-reviewed sense, in which we took carrier female dogs with Alport syndrome. These are young adult females who have stable proteinuria due to structural abnormalities in their glomerular filtration barrier. We put them on 1 milligram per pound per day of prednisone, and their UPCs as a group averaged 2.5. And in 2 weeks, the average went up 3-fold. In another 2 weeks, it didn't change. We took them off, and in 2 weeks it was back to baseline. And in another 2 weeks it was still at baseline. So if my view about hypercortisolemia, whether it's exogenous or endogenous, is that it certainly can take an existing proteinuria and amplify it. And we don't really know why, but it wasn't structural in these dogs. You know, in 2 weeks, it had to be hemodynamic or some effect on the cellular components of the filtration barrier. Okay. And so there are studies of people trying to take normal dogs and give them prednisone or steroid to make normal dogs proteinuric, and that doesn't happen very much. So the idea is if your patient has some cause of proteinuria and then has corticosteroid effect layered on top of it, it can amplify it quite a bit. And I too, now anecdotal rather than design study comment, recall consulting with a veterinarian who had a Labrador who was had an immense UPC on the order of 20, I think. And this Labrador was Cushing's, and he was talking to me about proteinuria. And I said, treat the Cushing's first, and then let's talk about the proteinuria. And as I've again, I got a wonderful memory. It's just short, but he did call me back, and we did talk. And if I'm not mistaken, the UPC was still abnormal, but it was something less than 2 after he got that dog's Cushing's disease under control. And I can't tell you what he used or how he treated it or what he defined to be good control. It's 20 plus years ago. But that's a clinical anecdote that sort of goes along with the thesis that steroids make pre-existing proteinuria worse and in a potentially reversible way. So steroids are good for treating proteinuria in dogs when the underlying disease that's causing the proteinuria is steroid responsive. But when it's not, it just makes the proteinuria worse.
Right. Which is interesting because you look at the dogs that are cushingoid that are then treated, and the majority of them remain proteinuric. So the question is it a duration? Was 2 weeks too short to cause structural changes via microscopic evaluation? Or these cushingoid dogs that finally are being evaluated after 6 months of PUPD and eating the garbage, maybe they have sustained structural injury at that time point. So it could be that short-term corticosteroids might have a vastly different effect than long-term hypercortisolemia. Larry Adams, you had your hand up. You want to share some thoughts?
Sure. We did do a study back published in '97 in JVM where we took normal beagles and gave them 2.2 mg per kg per day for 42 days. And we induced a low-level proteinuria mean of 1.2, and only one of those dogs was above 1.5. And then thanks, Bianca. The histopath, I guess I'm hesitant to stand behind because it was done just at like microscopic level by 2 pathologists at the time that were at Purdue that I respected a lot, but it was not what we do with the renal biopsies currently through the renal histopath service. So, there was suggested structural changes on that, but I'm not sure how firmly I can back that, if that makes sense. Our technology has progressed a lot since then.
Yeah, thanks for sharing that, Larry. I think that last statement is really important too, that when we look at some of these older studies, even the biopsy studies, and I'll paraphrase what I've heard Shelley say a number of times talking about her cyclosporin study, is that we really have a different era of our histopathologic diagnosis than some of these studies that came out now 15, 20 plus years ago. And we might see completely different outcomes when we're no longer diagnosing glomerulonephritis and maybe just leaving it at that off of just a light microscopic evaluation alone. So it's great to be in an era of more refined diagnostics, but it also puts some clouds on our interpretation of some of these older data as well too. Hope I didn't serve you wrong there, Shelley.
Looking at the paper, the responders, the first responders versus non-responders. 2/3 of the responders were female and half of the non-responders were male. It reminds me of the observation that we've had that the only category of histopathologic pattern of injury that is predominantly female is a non-immune complex mediated disease category that falls under the general heading of focal segmental glomerular sclerosis, which possibly is connected in some way, I think dogs in Europe female dogs are frequently or less frequently ovarian hysterectomized than in the United States, and so there may actually be a gender or even sex hormone difference underlying the prevalence of FSGS across the board, and that might be a category of glomerular disease that is proteinuric and less likely to kill you soon. And maybe, and I'm just guessing, it could be maybe more responsive to the hemodynamic effects on proteinuria that are induced by the enalapril, Basaril, or even maybe the ARBs. So there are lots of possibilities that all these people that I'm looking at name-wise can tease out as their careers progress.
And correct me if I'm wrong, Sarah, but when you guys looked at your FSGS cohort, I think you guys saw that survival was associated with azotemia and hypoalbuminemia, but you guys didn't look specifically at drug effect or response to reduction in proteinuria and survival. Am I right?
Yeah, we given the retrospective nature, there was pretty inconsistent treatment, and it's kind of one of those things that whenever you're looking at something retrospectively, it's super hard to tease out the effective treatment. I forget exactly how many dogs were on like ACE inhibitors versus ARBs versus standard therapy diets and things like that, but yeah, no, we weren't able to look at any of that. I guess it's something potentially you could go back and look at, but it'd be really hard.
Yeah, I agree. I thought this study the main study today was interesting in the way that they presented that categorical tree, and I can't say that I have a lot of experience coming across it in studies looking at the branches of essentially the effect of therapy and see. So I certainly had to go back and educate myself on that method because it's just not something we see, and it seems like a reasonable way of trying to make a retrospective data set less murky, but it's still going to be murky at the end of the day because as Bianca said, like you don't have standardized outcome dates, you don't have that's not controlled, so we're left with kind of exactly what we see here. Including just the very small number of dogs, only 10 dogs that had follow-up UPCs, and 3 of them were then not a responder based upon that. So if we extrapolate that 30% of dogs might heater above or below that point of what we call a responder, maybe we need to also define that a little bit more. And is it persistently responsive? Or how do we actually use those criteria overall? Sarah, do you have another comment?
Yeah, just looking at that tree, I think it becomes hard to make any clinical decisions based on this. I think it's interesting to look at, but I mean, like you guys have been saying all along, it depends on the disease diagnosis, right? So hypoalbuminemia in itself isn't going to be a negative prognostic indicator if you have an ICGN that's going to respond. Those guys can normalize and can live a really good amount of time with appropriate treatment. So I think it's interesting if you're in a limited environment, and say you are in a general practice and biopsy isn't an option. This is good information to be able to talk to somebody about. But ultimately, if you're in a specialty setting and you can get a biopsy and you can make a diagnosis, this information may or may not actually be relevant.
Yeah, I think that's a good point. It's trying to capture as much information as you can without knowing some of the drivers that are there in the processes, for sure. Aria, you have another comment? Not sure if you haven't raised your hand again, Aria, or if you're muted.
Sorry, my bad. I forgot to put my hand down.
No. Okay, just wanted to make sure you had it. Everyone got their chances. Okay, well, we have just a couple minutes left. Any other comments or questions or criticisms, suggestions, accolades on the paper? Larry Calgill, I saw you turn your camera on for a moment. I don't know if you had a comment or a slip of the finger.
Well, I'm not sure what I was going to comment on now. That was a few minutes ago, but yeah, I think it had something to do with the Cushing's. We did a study a long time ago that showed that these Cushing's dogs do get UPCs up in the 8 to 10 range pretty regularly. I don't remember what the follow-up was once they were treated, but again, to follow up on some of the other comments, proteinuria, is a marker, but George will remember Cooper Minton. This is a dog that presented with a UPC of 40, and for a membranous nephropathy, and with proper treatment, took over a year to get that dog treated, but then the UPC was down to 0.25. So these diseases the proteinuria can resolve with resolution of whatever the underlying mechanism that's causing the proteinuria.
He didn't just have membranous, he had early membranous with not a lot of structural change in connective tissue, GBM material. And so he's one of the cases that leads me to tell people if I'm a dog and I have to have glomerular disease, membranous is the one I want.
Well, we'll be sure to sign you up for that, George, if we get an option. Okay, well, we have just a minute or so left. Thanks again, Steph, for presenting. That was fantastic. And thanks for jumping in to get us started for our Journal Club series. We're very excited to continue this. Recordings of these sessions will be posted on the ACVNU's YouTube site. Postings will also be cross-referenced on the ACVNU website. So this will be archived for anyone to be able to listen who was unable to make it at this time point. And then our next meeting will be in 2 weeks on a Tuesday. And you could look out for more information on the ACVNU's website. I'll continue to post announcements on the ASVNU listserv because I think those folks are probably quite interested in hearing about it. I probably won't post again on the ACVIM listserv so that people won't hate me for crowding their inbox too much. But we will also post announcements on the ACVNU social media account. So if you happen to participate in social media, make sure that you follow the ACVNU and you'll get reminders as well too. So thanks everyone for attending. We had well over 70 people at this session, which was great to start out, and look forward to seeing you all real soon. So hope everyone has a great start to your week, and see you in about 2 weeks.